This is the most important thing for us to understand when it comes to looking at pharmacodynamic genes, as well as pharmacokinetic genes. Single nucleotide polymorphism. Before we talk about that, though, we have to look at the regular DNA, which is a double helix. It is a rung twisted. In a normal double helix strands of DNA, adenine always pairs with thymine normally, as well as guanine always pairs with cytosine. So you see that, right? You know, ATCG and twisted. So sometimes it looks backwards, but it doesn't really matter. They have to have matching pairs: adenine, thymine, guanine, cytosine. What is a SNP? SNP happens when there's variations. Adenine may not always connect with thymine. Adenine may connect with adenine, or adenine with cytosine, guanine. We don't know. We just have to look at the patient's genomics and figure out if it's normal or not. And this is how we know: through single nucleotide polymorphism. It is a variation at one specific position in the genome. So these minor differences can give us significantly different outcomes. These differences can have dramatic effects on the protein encoded, and what we see in our phenotype can be variable. I am going to talk about the pharmacodynamic genes, but however, I just want to pick on the top three, and if we have time, we're going to get through some of the other ones that I think that are fun, that we really need to understand, that helps us also pick and choose what medications to give our patients. I'm going to talk about the MTHFR gene. That was my favorite gene before, and I thought that was the answer to everything, but I've come to realize in clinical practice, not really. So I have to use my noggin and how a patient responds to it. There's people that would normally respond to the treatment for it, but then they don't. So still, we have to go back to us being clinicians and using our intellect, because we got here because we weren't dummies, right? So we have to use that and our critical thinking in how we guide a patient into their treatment. Because I had patients, like I said, I gave them treatment. And I thought this should have worked for you, but it didn't, or they had side effects. And if you don't consider other things, so this is why we practice precision psychiatry in what we do, because we have to think about all the other things. But for the sake of this lecture, I want to talk about like how I use genetic testing and how I use it to really help my patients. So the COMT gene, catecholamine methyltransferase, that's also a mouthful. This gene, depending on what you see, if it's either normal, high, or low, this is going to determine how you go about it, because it's very dangerous. If you don't know the difference, you can cause a bad outcome if you do not see whether a patient's enzyme activity to metabolize dopamine estrogen in your treatment plan. You could cause the opposite reaction or just make things worse. BDNF, talked a little bit about that. And these other genes, if I get to it, and I'm just going to pick a few that I think that is fun to know about in clinical practice, especially with the way that I'm moving towards more of a integrative, and I want to utilize lifestyle modalities to help my patients get better.